You are looking at a way of checking to see which patients have high-grade prostate cancer and therefore need more treatment. What were you trying to do here? Tell me, what was the main issue?
Well, it's not even more treatment, it's actually which ones even need a biopsy to be diagnosed, because we know that at least in the United States, 90% of men that are diagnosed with prostate cancer get treated for it. And most of these men have indolent forms of tumor that are never going to bother them, or they're never going to suffer from any prostate cancer sequelae. So the idea here is if we can not, leave those more dormant tumors lying where they be and try to focus our screening tactics on the more aggressive tumors that are going to affect someone's life, that's the goal of the 4K score.
And you've got something called 4K, a score. What is it?
So the 4K score, the backbone of it comes based on research looking at these 4 kallikrein proteins. They're basically similar to PSA. When you look at total PSA, it's actually encompassing all of these kallikreins. And what this test does is it looks at each kallikrein separately, because some of them tend to be associated more with prostate cancers, others more with BPH. So it allows a better discrimination between indolent and non-indolent forms of cancer when you look at them separately. And so this takes these 4 kallikreins. It also incorporates age, DRE, and prior biopsy findings, if whether patients had one or not. And from all of those information put together, it actually gives you a probability of a Gleason 3+4 or higher cancer on the biopsy.
You've got a very well thought out algorithm that should work. What did you do putting this to the test?
Well, I can't say, it's been developed by lots of different people over the years in terms of developing the actual kallikreins and finding them and the assays for them. It's been tested in multiple European retrospective cohorts, and I think to really show that it works in today's world in the United States, they did a prospective study looking at about 1,300 men, and about 1,000 of those men were kind of the validation cohort of it, and it looked to see if you were to use the 4 kallikrein test or the 4K score, what would be the impact in terms of identifying high-risk cancers and avoiding biopsies in men that didn't have a high-grade cancer. And we really found is that it discriminated between people that had low-grade cancers and high-grade cancers quite well. The area under the curve was about 0.8, which is better than most biomarkers, in fact, any biomarker out there.
Run me very briefly through what you did to establish that.
So it was about 1,000 men, all were referred by their urologist for a biopsy. So every man in this trial actually was going ahead to get a biopsy. They had a blood sample for kallikrein assessment done beforehand. So that would give the information in terms of what the levels of each kallikrein was. There's a simple, cover sheet for researchers looking at the age of the patient, what the DRE findings was, whether they had a previous biopsy or not. And all that's sent to OPCO labs. And OPCO labs will basically take the information they get from this, and the actual algorithm itself produces a percent probability. So when you get the test back, it'll say your risk of a Gleason 3+4 cancer is 7%, 10%, whatever it may be. And if you were to use this, let's say at a 9% threshold, you'd cut down on almost 50% of your biopsies and miss very minimal cancers, like high-grade cancers.
Theoretically, yes. In the real world, do you see this making an impact on the ratio of patients advised to have watchful waiting rather than active treatment?
Well, I do think so if it's applied properly. So I think what this test provides is better knowledge translation. Anytime a person's coming in with that elevated PSA and risk of suspicion of prostate cancer, there's a lot of uncertainty that goes into whether that person needs a biopsy or not. We know that there's a lot of downstream negative side effects that happen right after that man gets the biopsy, because as much as we want to divorce treatment and diagnosis, it's not an easy thing to do, especially in this country. So I think if we can focus our screening efforts on patients that are more likely to have aggressive and significant tumors by using things like the 4K score, we will be able to identify those men that have cancers that need to be treated, not identifying men that are better left unfound.
Your interesting findings then have clinical potential. What would you advise doctors to do about them?
So I would basically advise doctors to have a discussion with their patients about the negative side effects of finding a low-grade cancer, introduce the concept of active surveillance very early on, and as more and more men are becoming informed of the situation with prostate cancer and over-detection and over-treatment and are questioning the need to go through a biopsy, I think we have a right to provide them with information on just what their risk is. And that's where the 4K score helps, because it provides them exactly that in their own personalized risk assessment.
And your level of confidence is what?
Well, I think it depends on the patient. It's a little bit different. When we look at patients that are similar to the cohort that we looked at in this study, I think the level of confidence is well up into the 90%. I mean, we've used it in clinical practice, and it's really helped change kind of what I do. I think it does need some more validation in different types of cohorts, and they're doing that right now to kind of make sure that it's as robust as we all think it is. And remember, the kallikrein panel on which this test is based has been researched now for decades and has shown great results. This trial only showed that it can do the same thing when tested prospectively in the United States.